Good morning, everyone. After this fantastic session of this morning, my talk may look maybe a little bit too practical, but if you don't mind, I'm going to bring you in real life in the way we have to manage our patient. And definitely optimizing the ocular surface appears to be the true foundation for the success in refractive surgery. Why ocular surface matters in this area? Because the ocular surface is definitely the first refractive surface, and the tear film plays an important role for the stability, even if very subtle irregularities may induce big impairment, not only in functional symptoms, but first of all, in terms of visual impact. And so you can impair the diagnosis measurement, the refractive accuracy, the visual outcomes, and finally the patient satisfaction. So the dry disease is a common pre-existing procedure-induced condition. And again, as we mentioned yesterday, 10 years ago, nobody would have even considered the checkup of the ocular surface. We can estimate nowadays that, according to this 2024 ESCRS Clinical Trend Survey, that 17% of the surgeon doing laser surgery estimate that the patients suffer for ocular surface problem, and it's 2% when you go for SMILE, for lenticular extraction. So that we leads again to this visual impairment, and we again can emphasize the fact that the symptoms are not correlated sometimes to this visual impact, and the patient may express some dissatisfaction and will incriminate the surgery despite he may get 20/20 vision. That can even lead up to depression, even to suicide, and of course, by evidence, a loss in confidence to the doctors. So that's truly a very public health problem around the world. The key factors is definitely the lipid layer with MGD, because it does contribute to the evaporation of the tear film. That will increase with age. And don't forget that cataract surgery today can be considered as a refractive surgery. It will increase with the screen users, and I mean, most, even the children, they decrease the quality of the blinking, and we see MGD today, even in young people. It's underestimated, and that can be revealed after the surgery. So the effect will alter also the laser planning and may worsen all these symptoms after the surgery, and difficult again for the patients to tell him that it was a pre-existing condition if he was not tested and not informed. Tomorrow we're going to talk about this new focus on Demodex. It's new. Why? It's certainly new as an adjunct, but I mean, we do have now a targeted treatment, and that's why there is an interest today to look for it. So what should we do to check our patient? Before we have the access to this fantastic measurement of all the biomarkers, I think that we should all keep the value of one single drop of fluorescein properly just assessed. You put only one drop, and you wait enough to get so many great information about the tear film quality, the way you can stain the cornea, not only the cornea, but the conjunctiva. And of course, you add all of that to this live questionnaire, so we'll certainly move to the recommendation of the DEOSS, but at least check and collect all the symptoms. I think that without buying an osmometer or any kind of mammography, just looking at the stability of your regular mandatory images, which are the pachymetry, the topography, it's very important to look at just because that does reflect the stability of your tear film. And finally, the corneal sensitivity is also a very important marker. There is an overall health evaluation that also is mandatory. Check the story of the patient, of the family. Check all the surrounding conditions, the sport that he's performing, if he's a long contact lens wearer, because again, there is no correlation between signs and symptoms, and sometimes you do have organic lesions with decrease of corneal sensitivity that you won't diagnose before the surgery. And of course, then after comes this huge range of biomarking in general, coming with any kind of staining. Osmolarity, if you have the chance to get one, and maybe tomorrow we will get this fantastic platform of OIT. And that will be our dream, of course, to go deeper inside of the evaluation and detection, especially of inflammation. The imaging is also there, and it's not tomorrow, it's now available. Looking at the epithelial map is certainly two of the key factors. The stability of the aberrometry, and you know the OSI, which does reflect if the lens is clear, the retina with no issue. It does reflect the quality of the tear film, the meibography, and of course, the confocal microscopy, or maybe the IHD OCT that we've seen yesterday if the confocal disappeared. I wanted to bring to your attention maybe the value that we may add in the future in using IA in the field of ocular surface. And I'm involved in a research unit doing artificial intelligence and imaging in the eye field. But you will see that it's a tricky question for ocular surface. We were all looking for making objective measurement. Getting around of counting the tear breakup time or counting the dots of a keratitis. So it's how we did. We made this recording based on video to have, again, the goal of assessing the Oxford score and the tear breakup time. This database came first with the abstract slit lamp, but actually it's just putting with this ion imaging system your iPhone on the slit lamp that we collected the best videos. So we had to use this the CNN, so the neural network, to first segmentate and isolate the cornea, and then after to train all the model to go up to this level of these two key parameters. First source of disappointment. If you try to correlate what the observer is counting in terms of point for the keratitis, actually the IA get lost when you go up the grade of 2+. So we had to admit that instead of counting the point, we had to move to count the area of staining. And so for that, we went to this unsupervised visual odometry, the same strategy that is used from the autonomous driving algorithm coming from Google, except that for driving it's easier because the sun got always the same position and you work with the shadow. We use the same methodology. You take a frame, a second one, you do the superposition of the two of them and you calculate the distance. So in saying that, we had to face a first challenge. It's the fact that the slit lamp is moving and the eye is moving and the tear lab is unstable. So we had to go to the upper level and select in the different mathematical models the sigmoid 4, and now it's where we are. And you may know that for artificial intelligence, the proper way to calculate the accuracy is to do what we call the area under the curve that put together specificity and predictability and sensitivity. And all of that is good when it's 1, and you see here 0.93, so we're getting close. For the tear breakup time, we had to admit, based on the Siamese network, which is another strategy mathematical model, that we had to realize that when we are counting the tear breakup time, it's a zone. It's not a strict time. And so we had to determine the prediction, this area of rupture. And so now it's also very promising. The next step will be to work on a multimodal approach, putting together all the parameters that we are collecting. So there is definitely a promise to help us, I would say, in the way we can improve the accuracy. What are the key considerations for optimal surgical outcomes? Well, detect before, that means trying to find out the risk factors, the slit lamp, as we mentioned already, and to refine if needed with some imaging fluctuation and sophisticated tools. But treat and postpone surgery, that's also something that we should consider. And even control and even cancel if there is no control of it. Prefer surface ablation or maybe KLX if there is an obvious OSD. And patient information, it's very important to avoid any disappointment after the surgery. Protect during, that means topical anesthetic. Don't use too much of them because you will limit by this way the toxicity. Speculum and light microscope with the suction ring, save light, all of these are also source of toxicity. And surface lubrifications, keep away wet along the surgery, that's also crucial. Check after, close monitoring, reinforce the lubricant, a long follow-up when it becomes chronic, and of course, you need to graduate your treatment from artificial tears up to the general, and of course, general treatment when you have to face the neurogenic component. Post-operatively, and it's certainly too late, so I would recommend to manage MGD when it's obvious, with the regular way, warming, waiting, and massing your leads. And you restore your tear film. And to me, when you have to go through this inflammation modulation, starting with steroids, it's not an issue. Going to the second line is something that should be an alert. When you have to preoperatively start with cyclosporine, autologous serum, insulin drops, that means that it's going to be challenging. So in total and in conclusion, I would say that ocular surface optimization is based now on a well-defined strategy. You can personalize a severity-based treatment plan. That means that you address inflammation proactively, and with mechanical therapy, you can control the MGD, but that doesn't mean that you need to jump on inflammation for all patients. Patient education and lifestyle modification make it more sensitive and responsible, and the patient will be proactive in the strategy, because when he doesn't complain, he needs to understand that it's still useful to be pre-treated, and preoperative treatment improves all the quality of the measurement, and by the way, the predictability of your measure. So these top pearls are here. Screen every patient, even asymptomatic. Identify the road score and treat accordingly. Dealer cancel refractive surgery if ocular surface is unstable. Reassess the ocular surface after treatment, and inform and educate patients on the impact of OSD. Thank you very much for your attention.